Now let's talk about the retinal venous occlusive diseases. Retinal vein occlusions are more common than the artery occlusions, and it typically affects elderly patients in 6th or 7th decade. And now talking about the etiopathogenesis, it results due to the thrombus formation. And the predisposing factors are age, hypertension and diabetes, hyperviscosity of the blood due to polycythemia, hyperlipidemia, and there is periphlebitis retini, that is central or peripheral, and there is raised intraocular pressure that is common in patients with primary open angle glaucoma. And also due to the intake of oral contraceptive pills in young females and the hormonal replacement therapy in elderly females, it may lead to the retinal venous occlusions, and smoking and local causes like orbital cellulitis can also lead to the venous occlusions. And now talking about the pathogenesis, pressure on the veins can be due to the atherosclerotic retinal artery, and secondarily, it induces thrombosis in veins in some predisposed patients. And according to the Versus triad, factors for venous thrombus formations are slowing of the blood stream, changes in the vessels wall, and changes in the blood. And now talking about the classification to retinal venous occlusive disease, there could be central retinal vein occlusions and branched retinal vein occlusions. And in central retinal vein occlusions, it could be impending CRBO, non-ischemic CRBO, and ischemic CRBO. And in branched retinal vein occlusion, there could be hemiretinal, quadroretinal, and small branched retinal vein occlusion. And now talking about the central retinal vein occlusion, it can be non-ischemic and ischemic. And now talking about the non-ischemic type, it is also called as venous stasis retinopathy. And it is most commonly seen in 75%. And the clinical features are, the symptoms could be mild to moderate visual loss, sudden painless unilateral blood vision, and the signs could be visual acuity would be impaired, but it is moderately impaired, and the RAPD, that is relative afferent pupillary defect, is absent or mild. And now talking about the fundus examination, in early cases there is mild venous congestion and tortuosity. Few superficial flame-shaped hemorrhages are more common in the peripheral regions, and there could be mild papillary edema, or there could be mild or no macular edema. And in late cases, after 6 to 9 months, there could be seething around main veins, and there could be cilioretinal collaterals around the disc. Retinal hemorrhages are partly absorbed, and chronic cystoid edema can also be seen in moderate cases. Note, about 15% cases of non-ischemic CRBO converted into ischemic CRBO in 4 months, and 30% are converted into ischemic CRBO in 3 years. And now talking about the ischemic CRBO, it is also called hemorrhagic retinopathy, and it refers to acute complete occlusions of the central retinal veins, usually occurs in elderly people with, say, cardiovascular diseases. And now talking about the clinical features, the symptom could be sudden severe visual loss, and the signs are visual acuity is worst, and the RAPD is marked. And while doing the fundus examination, in early cases, retinal vessels shows massive engorgement and tortuosity. The retinal hemorrhages are very much massive. Almost whole fundus is involved, and it gives splash tomato appearance. And cotton wool spots are also seen. Optic disc shows edema and hyperemia. Macular area is full of hemorrhages and edematous too. And the breakthrough vitreous hemorrhages can also be seen in some cases. In late stages, there is marked seething around the veins. The collaterals are seen around the disc. There is neovascularization at disc and periphery. Macula shows marked pigmentary changes, and chronic cystoid edema can also be seen. And now talking about the branched retinal vein occlusions, hemispheric, quadrantic, and small branch occlusions. Hemispheric is due to the occlusions at main branch as disc. Quadrantic is at the level of AB crossings, and small branch occlusions are as macular branch occlusions or peripheral branch occlusions. And now talking about the clinical features, the vision is affected only when macular area is involved. Retinal edema and hemorrhages are limited to area drained by affected veins only. Secondary glaucoma occurs rarely, and chronic macular edema and neovascularization may occur as complications of BRVO in about 1/3 cases. And now talking about the management, first of all, clinical evaluation and investigation should be done. Now, ocular examination. And while doing ocular examination, visual acuity is taken. That is, at presentation and at every follow-up, visual acuity should be taken, and intraocular pressure should be recorded, and associated primary open-angle glaucoma should be ruled out. And undilated slit lamp examination should be done to detect neovascularization of iris. Gonioscopy should be done to rule out the neovascularization of the angle, and fundus examination with direct and indirect ophthalmoscopy should be done. And after ocular examination, ocular investigation should be done. Goldman perimetry and ERG should be done to differentiate between non-ischemic CRBO and ischemic CRBO. Fundus autofluorescence should be done. Fundus fluorescence angiography should be done to assess state of retinal perfusion after resolution of retinal hemorrhages. And optical coherence tomography should be done for evaluation of macular edema, subretinal fluid accumulations, and development of epiretinal membrane. And now talking about its differentials, it can be and its differentials could be diabetic retinopathy, but diabetic retinopathy is bilateral, but CRBO is unilateral. And its differentials could be ocular ischemic syndrome, but in OIS it is due to the carotid occlusive disease and it has only dilated veins without tortuosity, but in CRBO tortuosity is also present. And now talking about the treatment. First of all, treatment of systemic and ocular associations should be done like hypertension, diabetes, hyperlipidemia, primary open-angle glaucoma. And then observation and monitoring should also be done. And now talking about the treatment for macular edema and neovascularization, there is medical therapy, laser therapy, and surgical therapy. And now talking about the medical therapy, intravitreal anti-VEGFs can also be given, that is 1.25 mg bevacizumab or 0.3 mg ranibizumab can also be given, and it should be repeated every 1 to 2 months. And intravitreal triamcinolone 1 mg per 0.1 ml can also be given, and intravitreal dexamethasone can also be given in alternative cases. And in laser therapy, pan-retinal photocoagulation can also be done. Scattered laser photocoagulation can also be done. And in surgical therapy, pars plana vitrectomy for persistent vitreous hemorrhages and tractional retinal detachment can be done.